Hey guys, welcome to CRNA School Prep Academy podcast. I'm your host, Jenny Fennell, CRNA, and founder and CEO of CRNA School Prep Academy. So today's topic that we're going to cover is which ICU is best for CRNA? This is a very common question I get asked from my students, so I figure might as well go ahead and address it here on the podcast. So there are lots of ICUs to pick from out there, and there's also some misconceptions on what an ICU is. And the CRNA school requirements are very specific and actually tailored based on what school you're looking into. And so I'm going to try to give you the best advice I can give you, but ultimately, I want to start all this off with saying you need to be researching your particular school that you're interested in. Even if you're applying to more than one school, you need to be thoroughly researching every single school that you're going to be applying to see if there's any differences between their ICU requirements. So the standard that is set for all CRNA schools across the country is that it has to take place in the United States. Your ICU experience, again, needs to come from an ICU within the United States. And it needs to be high acuity, and you need to be dealing with advanced life support and different hemodynamic monitor systems in your experience. And so, schools, it's up to them to kind of decipher what that means as far as what kind of units they prefer. It doesn't mean that a school prefers NICU over SICU or CVICU over NICU or whatever all the ICUs are. There's so many of them. Ultimately, this is a school's preference, essentially, and not all schools will take a NICU or PICU experience. And these schools kind of base their standards on what they think a successful student displays in their program. Meaning, historically, if you look at the data, do students who come from the NICU, PICU pass boards the first time versus a student who came from the CVICU? And so that's kind of how they kind of judge whether they accept certain units versus others. And so I'm kind of going to, again, let you guys know that you need to be researching your school first and foremost to see what units they prefer. And essentially, the units that are the safest units are any adult ICU. And there can be so many different types of adult ICUs out there. You know, there's the SICU, the MICU, the CVICU, the CCU, the burn trauma unit. I mean, you can combine those letters any way you want to make any kind of ICU. There's even a SICU-MICU combination ICU. So it doesn't really matter as long as the acuity is there, that's okay. The reason why NICU and PICU sometimes don't count is because they feel that that's such a very specialized ICU type of experience, and maybe is not the best tailored for CRNA training. I don't necessarily believe that to be true. I've seen plenty of NICU and PICU nurses go on to be very successful. I've worked with NICU PICU nurses before or I should say prior to anesthesia, they were NICU PICU nurses. They're brilliant. And in fact, one of the PICU nurses I did recently work with said one of the advantages of being a PICU nurse prior to anesthesia was the fact that she already knew weight-based calculation and dosing of drugs, which is something that I definitely did not know coming from a MICU background. So again, every background, whether it's neuro or surgical, medical, cardiac, NICU or PICU, you're going to have certain strengths, okay? But you're also going to have weaknesses. The reality is you can't gain all the experience on one unit. And so the key with trying to pick what unit is best for you to gain your ICU experience prior to CRNA school really comes down to what is the acuity like? How often do you titrate vasoactive drips? How often are you managing vents? And really, do you manage vents at all? Most ICUs, especially the bigger ICUs, have respiratory therapists who manage vents. And there's nothing wrong with that. You still have to be able to troubleshoot the vents yourself to go get an RT to take a look at things. So essentially, even though you're not the one actually making the respiratory changes, you would have to be aware if there was a problem with the patient and also be analyzing blood work to notify the team of potential ventilator issues. If you're seeing that their blood gas came back, that was all out of whack, or whatever labs, again, that you're kind of analyzing as an actual ICU nurse. And so again, picking a unit where you don't see a lot of ventilators, where you don't titrate a lot of vasoactive drips, where you don't see a lot of advanced life support like CRRT or ECMO or balloon pumps or VADs, ICU or Ventrix, ICP bolts, those types of things. You may essentially be not in a high enough acuity unit, okay? If most of your patients are awake and able to talk to you, that's probably not a good indicator that that's a high acuity ICU. So a lot of people will tell you need level 1 trauma experience. And the reason for that is it's not because it's a level 1 trauma, because level 2 trauma is actually essentially the same as far as acuity goes. It just, the biggest difference is the level 1 tends to have more opportunities for research and tends to be at more like academic facilities. But the acuity essentially is usually about the same. But essentially you can have a non-trauma hospital and still have high acuity, but you have to still frequently see ventilators and patients who are on advanced life support. Or as soon as your patient needs a ventilator or needs vasoactive drips, or maybe needs Prisma or CRRT, do they get shipped to the nearest trauma center? So that's what I want you to ask yourself. And so when you're interviewing for these ICU positions, you need to be asking the manager, what's the acuity like? How often will I be titrating vasoactive drugs? How often would I be managing ventilators? How often would I potentially get extra training in other advanced life support measures like CRRT or ECMO or those types of opportunities? So it's important to be asking these questions when you're taking your ICU position. And again, remember, based on what unit you work on, you're not going to be able to get all the experience. You're not going to be able to do ECMO and Prisma and VADS and Impellas and Ventrix and ICP bolts. You just can't find a unit that has it all. And it's okay not to have it all. You just have to have something. You just have to have something a little bit extra that puts you in a unit that says to the admissions committee, okay, they clearly came from a high acuity unit because they were taking care of X, Y, and Z. And so again, and as far as PICU, NICU experience, you have to really know whether your school prefers that or not. If they say on an individual basis, what that says to you is they don't prefer that experience, but if you're an overall good candidate in every other way, they'll consider you. I don't necessarily think that's putting your best foot forward going into your application. So as much as it kind of stinks and it seems unfair, and not that I'm at all encouraging any of you to pursue pediatric anesthesia, because I personally do pediatric anesthesia. I love pediatric anesthesia. I just think, unfortunately, if you live in an area with one school and that's the school you want to go to, if they only consider NICU, PICU on an individual basis, you're probably better off getting your experience as an adult ICU prior to applying to school. And then you can make your shift into pediatric anesthesia after school. The reality is too, in school, you only spend about 3 months of your entire training actually training at a pediatric hospital. The rest of the time you're working with the adult population. And so while I don't think it's impossible for a NICU, PICU nurse to come in there and acclimate to the adult environment, it probably would be more of a challenge considering the vast majority of your training is all adults. And keep in mind too, even if you did NICU, PICU, that's okay. And especially if a school says, yes, we take NICU, PICU, by all means, get that experience. But you're still expected as a candidate to know the difference between a baby and an adult, cardiovascular wise or hemodynamic wise, how to manage those two different types of patient populations. You still need to have an idea of the fact that the physiology is different from a baby and an adult. And why is that? They could potentially ask you that in the interview. So just because your background's only NICU and you really understand a NICU, a neonate's hemodynamics and fluid shifts and how to manage them, you still have to have an idea of how is that different than an adult. So I encourage you, if you do gain that experience in the NICU, PICU, that's okay, but just make sure you understand the difference between adult and kids as far as hemodynamic monitoring and management. And again, if the school says on an individual basis, I would see that as a red flag. It doesn't mean that if you want to try it, that's totally fine. Plenty of people get in with on an individual basis, but knowing that going into your application, just make sure that you're highlighting what your strengths are coming from that background and really sell your experience. Make sure your resume really highlights your attributes that you're bringing to the program. Try to think of ways that even if they try to say, well, how are you going to handle this if your experience is only this? How are you going to acclimate to the adult world? Make sure you're really thinking about those hard questions they could ask you and potentially confront you off guard when you're in the interview. As long as you have a way to sell yourself, you're going to be okay. Some of the units I want to caution you about, one of them, the main one that's probably the most common unit that people don't realize is not considered ICU in a lot of settings, is ER experience. And the reason why ER, I know they get a lot of traumas. You see the really sick patients coming in the door. You're the first responders. You're right there in the action, but you then simply stabilize the patient and get them up to the unit. You're not managing them long-term. And so they really like about the ICU experience is that you're actually managing these patients for an entire shift, that you're not just stabilizing and shipping out. And so that is why ER experience, for the most part, in a lot of schools' eyes, is not equivalent to ICU experience. Now, I've heard of nurses who actually have like a ICU bay in the ER, meaning they keep patients longer because the beds are full in the actual ICU. So they actually have an ICU bay in the ER. Unfortunately, if the school is not super familiar with that hospital and with that system, they may not understand what that's like and really understand how that's qualifies as an ICU. And so again, that's where it really takes your resume to really display that to them. But if a school only considers ER experience on an individual basis, it's not going to be exactly what they're looking for. It's not going to be their preference. They'll consider you, but it might not be ideal. And the only way to really set yourself apart is to really sell your experience on your resume and make sure you're knocking your interview out of the park. Okay. And a vast majority of schools out there actually say no completely to ER experience. And so this is something that I see a lot of students kind of, struggle with when they get all the way to the application process. And then they realize this when they go to apply. And it has to be gut wrenching to realize you just spent the last 3 years working in an ER and your school does not even accept ER experience. I don't want to see that happen to you. So please, I'm stressing to you, make sure from the day you decide you want to do CRNA that you're thoroughly researching your school. Go to their website. There's another website called the COA, CRNA.org. So it's www.coacrna.org. And you can look up your school's stats on that website. But most of the time, these schools are listing their accepted ICU experience on their website under the admission requirements. You could also give your email to these schools and they can actually send you more information. So please do that early on in your path to CRNA. Although I do understand there are some people who don't necessarily choose CRNA until maybe they see CRNAs at the bedside in the ER, placing central lines or doing airways. I get it. Sometimes it happens. Sometimes you just don't know that you want to go on for CRNA until you've actually experienced being around some CRNAs. And so at that moment, I encourage you to start researching your schools. If you're even questioning CRNA, start researching your schools. And that way you make sure you're getting the experience they want. And, unfortunately, will they make exceptions? No, they don't have to make exceptions. They get plenty of applicants. They don't need to accept someone with what they see as less than ideal experience. And remember, they're looking at data. They're looking at board passing rates and then going back and seeing the characteristics of the students who passed boards the first time. And historically, the students who passed boards on the very first try have adult ICU backgrounds. Now, PICU does very well. And you look at the data, PICU nurses tend to do very, very well, but ER and NICU tend to be on the lower side as far as board passing rates on the first time. Now, who knows if it really truly 100% correlates? All they have is the data and the statistics to go by. So these schools are all looking at things like that. And so that is kind of how these schools make their decisions based on what units they accept. Now, I'm also going to say there's units such as cath lab, PACU, and OR that do not count at all. And some of you may be thinking, well, wait a minute, I know a nurse who got in with cath lab experience. Well, that can be true, and this is why. So some schools do not require current ICU experience, meaning if a nurse has previous CV ICU experience and then decides to go work in the cath lab, and then from there applies to CRNA school and gets accepted, that counts because they've had CV ICU experience in the past. The opposite's also true. And the fact that you can have, say, 4 years of SICU experience, then you can go to the OR, go to apply to school and be told, no, you need current ICU experience to apply here. And you'll be forced to go back and work in the ICU prior to applying and interviewing for school. And so all schools, again, can have a slightly different viewpoint on whether they want their students to have current ICU experience versus within the last 2 to 3 years. I will say that when schools say they want ICU experience within the last 2 to 3 years, I still think the most competitive candidates are current ICU nurses. And, so I don't want you to be fooled by that kind of leeway they give you, because I still think the best thing to do is have current ICU experience to be competitive, considering how competitive these programs are. I can't tell you how many times I hear students talk about when they get feedback from these schools as far as why they get waitlisted. The only thing they had to say is it was a competitive application cycle. It was competitive. They had way more qualified candidates than they can actually take. And so that being said, you really want to have that competitive edge, and that could be potentially a slightly more competitive applicant who currently has ICU experience, who hasn't been out of the ICU for the last 2 years. So keep that in mind. Does it mean it's impossible? No, it does not mean it's impossible. It just means preference-wise, they probably still prefer a current ICU experienced nurse over someone who's been out of the ICU 2 to 3 years. Unless you interview and you knock it out of the park and your resume and everything else really shine, like I said, I really think to put your best foot forward, you need to have that current ICU experience at the time of application. But don't feel discouraged if you don't, if your school only says within the last 2 to 3 years. Go ahead and apply. It's worth applying, but I want to make sure I point that out. So nurses who only have OR experience and only have PACU experience and only have cath lab experience, it'd be very unlikely to ever gain acceptance in anesthesia school with just that background. Now, I can't say 100% that that's never happened, because I don't know everything that's ever happened in the history of acceptance to anesthesia school. I do know a lot of networking goes a long way, meaning if you're going to the open houses, touching base with the program director, showing your interest, and if you can display really good critical care ICU knowledge, or maybe you were an EMT once in the past and now you're a cath lab nurse, maybe the EMT, potentially a program might overlook that and say, well, they do have EMT experience, they really rock their interview, they clearly have good ICU knowledge, maybe we'll let this one slide. I can't say that's never happened, because I'm sure it has, but that's the outlier. Okay. That's not the most average or common thing to happen. So I don't really want you to count on that, essentially. All right. So we've addressed those units of experience at this point. I also briefly touched on doesn't need to be current. That's something that you need to be looking into. I actually just had a student who had gained, he had CICU experience, and his only saving grace with this whole experience he went through was the fact that he actually had a lower GPA. He decided he didn't know if he'd ever get into CRNA school, but he really wanted to, but he was burnt out in the ICU, didn't want to do ICU anymore. So actually made the change to the cath lab after he applied to CRNA school, even though he had no hopes of actually getting in. He said he really didn't think he'd ever get in, but he just figured he'd give it a shot. Well, the student actually got an interview with his program. He did awesome in his interview and actually gained acceptance. To his surprise, he gained acceptance, but he currently worked in the cath lab. When his program found out, after he gained acceptance, when his program found out he currently worked in the cath lab, they said, well, if you don't go back to the CICU where you originally were, you're going to lose your spot. We're going to give your spot to another student. So at that moment, he only had a month or less, or a month, 2 months maybe, to get it back into the surgical ICU. And again, his saving grace was the fact that he stayed PRN in the CICU when he went to the cath lab. So he still occasionally moonlighted over there. And so he was able to easily get back into the CICU full time as a nurse from the cath lab. And that saved his spot in his program. So I'm telling you that story because that would have been so awful if that was not the case. And he actually had to go through all of that and get in, and then not actually be able to go forward with it just because he changed jobs. So that's a big deal. I want to make sure you know that going forward, so you're not just making these decisions without actually knowing what their policy is. You have to know your program's policy, what they expect from you. Some programs expect you to be full-time in the ICU up until the day, or not the day, but up until the month or two before you start school. Does it mean you have to work up until the day you start school? No, it definitely does not. A lot of students quit, a month or two prior to starting school to get everything in order, and maybe go down to PRN in that time so I can kind of gather everything and make sure they're ready to start school. Doesn't mean you have to work up until the day that you start class. But again, going back to the acuity issue, I really think when you're looking at acuity, don't just look at level 1, level 2, level 3. Actually analyze what kind of tasks the nurses do on the unit, and what kind of opportunities exist for you as a nurse for leadership, for research, for advanced training on different advanced life support systems. There are some units that don't really promote leadership in any way. There's no committees or nothing for you to join. I've heard some, which is odd to me, and I find it very unusual, but I have talked to a couple nurses who are on units like that, where there's very little opportunity to get involved. So these would be great questions to ask during your interview, because some schools put a lot of emphasis on leadership roles. Do you precept? Do you take charge? They like seeing those types of roles. What kind of committee work have you done within the unit? Research is another thing too. And again, not all hospitals will have opportunities for you to do research. Level 1 trauma hospitals usually always do, but go up to your attending that's a fellow on your unit and ask them what they're involved in. They're probably doing some type of research or literature review that they'd probably be happy to have help with. And so if you just offer your help, your services to do a literature review, that would count as being involved in research. So there's always something you can do. Talk to your clinical nurse specialist on your unit, see what projects they're working on, and maybe see if you can take the lead on that. Maybe talk to your nurse manager and see if you can survey all the nurses on your unit about a particular topic that maybe needs addressed on. Maybe survey your unit and see what they're unhappy with. And then whatever the consensus is, maybe come up with some kind of system or game plan to address that issue. And so that's taking the lead in that role. So those are the types of experiences that can really set your ICU experience apart. And, again, back to the beginning, you guys, research your school. That's probably the most important aspect of it, is research your school, know what they're looking for, go to the open houses, and talk to current SRNAs that are there. And again, it's not so much about whether it was a neuro ICU or a SICU or CVICU. I've heard so many students say, well, they prefer CVICU. So I've had nurses who have had, 3 years of surgical ICU experience, good experience, question whether they should leave to go to the CVICU because they think that's what the schools want. And that's kind of upsetting, because I don't think that that's 99% of the time what they should actually do, because then you're going to be starting all over again in a new unit with no leadership experience in that unit. You're going to be the brand new person on the block, meaning you're not going to be taking the most acute patients. So it takes time to really build your presence in a unit and be that nurse who takes the sickest of the sickest patients. And so when you're giving up an experience of 3 years in a surgical ICU, when you're probably getting some of the sickest patients, to go to a brand new unit to start taking not the sickest patients again, I don't necessarily think that's the right move right before you apply to anesthesia school. And usually the CVICU nurses who get trained to do things like ECMO, they've been there for a while. So do you really want to spend another entire year gearing up in the CVICU when you could have just increased your leadership activity already in the surgical ICU that you already worked in for 3 years? And remember, references, so the longer you work somewhere, the better reference you're going to get. Some ICUs won't even give references if you've been there for less than 2 years. So keep that in mind. If you're leaving a unit you've been on for a while to go to another unit that you think is better, how long do you plan on being there? And do you know their policy on giving references out? Maybe that's something to ask in the interview. Do you give out references? Not that you don't have to say that it's because you're going back to anesthesia school in a year, but you could say, well, I eventually would love to further my career. And, again, that's all they have to know is you want to further your career. You want to become an advanced care provider or advanced practice nurse. So asking whether they can provide references, and maybe they'll tell you, well, yeah, we do, but we require you to be here for a minimum of 2 years before we will provide you that reference. Well, that's a big red flag, especially if CRNA school is right around the horizon. I wouldn't go to that unit, or make sure that you can potentially stay PRN at your other ICU so you can ask your old manager for the reference. So if you really come from a unit that's not high acuity and you need to leave, but you want to apply to CRNA school soon, and the unit you're going to doesn't give out references in a certain period of time, stay in touch with your previous nurse manager, maybe still moonlight there so you can still say you're current at that facility and get a reference from them while you're actually gaining better ICU experience. One last thing I'm going to touch on today is travel ICU nursing. That's a very common thing these days, and it's very well paid. And I think it's a great way for students to save up money prior to school. However, there could be some kind of little bit of a debacle on whether that's a good idea or a bad idea. And I've actually heard from several different program faculty, and I've heard various responses. So it's kind of interesting to me that it's not really universally looked upon in a good way or a bad way. Some programs wonder if they see you traveling, if you can't commit to one unit, that maybe you're running from something, that maybe you have a hard time with long-term relationships of some sort. I think that that's kind of silly sounding in my mind. I think the vast majority of people who do travel ICU nursing do it for the money. But I just wanted to point it out because the program director actually, or assistant program director actually said that. So it just was a new spin on how they potentially can see travel nursing. I've had plenty of programs who think nothing of it. They think it's fine as long as you have solid references. Travel nursing is very common these days. And again, it's a very common method that SRNAs use to save money before school. The vast majority of SRNAs I know get their travel experience from the time of their acceptance until right before school, meaning apply to school, look into travel positions, and kind of try to time it so you would start your travel ICU experience after you gain acceptance. And they mostly do this because they want to make sure that they have solid leadership experience and references prior to applying to school. And it's hard when you're traveling every 3 months to gain those things. Okay. It's hard to get involved on a unit leadership committee when you're gone every 3 months and on to a new assignment. The other option, if you really want to travel sooner than later, is to get a home base established, maybe get a year of experience on a home base, and then stay contingent there. So in between assignments, you can come back and work for a week or two. And so technically, there's still a current employer that can actually offer you a reference when you actually go to apply to anesthesia school. But then in between assignments, you could still do your travel and then go back home and work, for a week or two, like I said, in between assignments. So that's an option to kind of get around that a little bit. But again, I've had a lot of students who kind of wait to travel just right before they actually start school. They take maybe 2 or 3 travel assignments in that time and save up money that way versus the entire time they're an ICU nurse. So I see that being the most common route. But I think it's a great idea. I don't think it's wrong to travel. I just think you need to be smart about thinking about leadership opportunities and unit committee work. And again, as a traveler, you're more than likely not going to get the sickest of the sickest patients. Another mistake I see travel nurses make is they take these travel assignments, but they're not to level 1 ICUs or any trauma level ICU. They're just to an ICU that maybe the patients are really not that acutely sick. And so potentially you could lose your ICU skills over the time doing travel ICU. So it's really important when you do seek out travel assignments that you're really seeking out the sickest travel assignments. And I think the way to do that is to already have a solid ICU background. Meaning if you're a relatively new ICU nurse with less than 6 months under your belt, chances are a travel assignment, you may not get the sickest travel assignment. If you already do things like ECMO or Prisma, and then you look into travel ICU nursing, you're more likely to get assigned these sicker patients because you already have some good experience under your belt and you're already trained additionally for other life support measures. Does that make sense? So keep that in mind too when you're looking at travel positions. Make sure you're actually taking high acuity units when you are traveling. And then one last thing with the travel is that let's just say you didn't stay contingent at your first home-based job, or you went to traveling shortly after you graduated. You can always travel for 2 years, let's say, and then maybe think back to what was your favorite hospital that you really enjoyed, not only the location, but the work environment, and the acuity was really high. Go back to that location and then stay there for 6 to 8 months prior to anesthesia school, and then get that reference and go to school after that. That's the next most common way I see students kind of get around this debacle is they pick a travel assignment they like the most and then actually sign on as a staff there and stay there for 6 to 8 months prior to applying to school and gain a reference that way. So I hope that helped you guys. Hope that kind of helped clear the air a little bit on ICU experience. I know it's kind of a tricky area, but your best bet if you're not sure is to ask your program what their thoughts are on particular units, especially if it's something that's kind of unique, like a ICU holding bay inside an ER. just make sure you're actually reaching out to your program and asking these hard questions and hearing it straight from them. Again, go to open houses, network with current SRNAs at your program. That's always the best way to get information. I hope you guys have a good week, and we'll see you next time.